Men ja, når mikrofonen er på, så er det
så. Yeah, welcome everybody. My name is Kåre Christensen. I'm one of the chairs here at DIAS, Danish Institute for Advanced Studies. And on behalf of DIAS, it's a great pleasure for us in these difficult times to be able to present Lone Simonsen, who will talk about pandemics in the past, the present, and the future. And I guess most of you know Lone. She's a very recognized capacity in the field of epidemics and pandemics, not only in the scientific community, but also in the public as a very often excellent communicator of the problems and the science behind pandemics. And I must say Lone has an excellent background to fill these roles in the public and in the science. Lone took a master in biology and chemistry at Roskilde University back in the 80s. Afterwards, she went to University of Massachusetts and did a PhD in population genetics. And then in the 90s, she worked at the Center for Disease Control in Atlanta and the World Health Organization in Geneva. And then she moved on to the National Institute of Health in the branch of allergy and infectious diseases, and still with a strong ties to WHO. And then from 2007, she became a research professor at Georgetown University.
George Washington University.
George Washington, sorry. And then, luckily, Lone returned to Denmark and is now back where she started at Roskilde University in professorship and with population health as the topic. So, welcome very much.
Thank you so much, Kåre. It is a pleasure to be here, and thanks to those of you who actually braved the situation and came here. I thought, since given the times and everything, that I should add the dash with the focus on COVID-19 to my presentation. But really my focus has been on these studies of pandemics of the past, present and the future for maybe almost 30 years, I'm afraid, actually. So it was a great pleasure for me to actually discover that this point of view, coming from a very rich understanding of the history of pandemic diseases, actually turned out to be important in the context of COVID. So I'm here on behalf of my whole team at Roskilde University, and we have gotten a Carlsberg Foundation grant to actually study these things, modeling of pandemic diseases. And like many of you probably here, we are a very interdisciplinary team, so that's a lot of fun. I wanted to just make a little outline so you can follow what I'm going to do. I'm going to start just giving you a little flavor for this pandemics project that's going on at Roskilde University. Then I'll talk about what makes a pandemic, what does it really take for a virus to do this trick, and what is the historic experience with that kind of thing, the pandemics that actually occurred and the ones that didn't quite make it. And then I will spend most of the talk on the COVID-19 pandemic, both on just review all the facts that we know about this now. It's like been like sailing a boat while you build it. That's how it has felt with us. Just even the simplest thing we didn't understand for a long time. And I have like an aha experience with the super spreading phenomenon that I can hardly get my arms down over. So I'm going to talk about that in the end of the talk. And then of course we have to discuss how will all this end, what's going to happen to us and what comes next. Because surely this is not the last pandemic we have to live through in this world. So this is the pandemics group as it stands now. We used to just be a few people spanning from mathematics to history across the biology. But now we have a very rich consortium of young people who just really added from all kinds of angles, both in bioinformatics, math, physics, and medicine and history. And we also have a few people I worked with in the past who actually are very good at telling the story, finding what's interesting in what we know. We also are, I naturally have a lot of international partners because I was in the US for so many years. But also now I'm trying to actually make us also work well with institutions across Denmark and the Nordic countries. And here you see some of our Danish collaborators already. We're developing a very strong tie with the Niels Bohr Institute through Kim Sneppen, doing this Superspreader and other interesting sort of agent-based model research on COVID. And then we have a very exciting new collaboration with Anders Gorm Petersen at the DTU. We're trying to understand, maybe can we use the sequence data to see if there was a coronavirus pandemic in the past that we just didn't think about. And then at the Statens Serum Institute with Robert Skov, Kåre Mølbak, and all those good people out there, we're trying to collaborate on as academics, assisting with information and analysis when we can. And that has been very interesting and good stuff. And then Thea Kølsen Fischer, who I worked with for a long time, and her colleagues at Nordsjællands Hospital, we actually have access to some real data who are actually seeing real people and patients. So the big idea behind this whole research endeavor is really that, I mean, if you're an economist, could you imagine going into this world and saying something about the current economy if you hadn't studied the Great Depression in the past and other sort of ways to handle economics, the history of it? For some reason, this field has for a very long time behaved as if we didn't have to do that. Public health is not naturally very involved in history. So we're just thinking, and I've just been at this for probably 25 years or something, trying to make this a thing, is to say, what if we studied quantitatively historical pandemics and we really had a whole lineup of what has happened to us in the past? Wouldn't that shed light on the present and future pandemics? And then came COVID. So the tools that we used is data digitalization, creating the databases from historical health records and contemporary, and then mathematical models, statistical models to understand what it meant. And the task here is to study, I call it the signatures of the pandemics. You can sort of map them on what they did to the population. And in that way, it's very different from what, for example, RNA researchers would do or phylogenetics researchers would do. It's really an attempt to understand the impact on the population. And in order to do that, you really have to have a strong idea about the context. So that's why we work with social science and humanities. So the models we use are two types. The statistical models that we used to simply find out what happened, how many people died of this pandemic, did this vaccine work? Lots of data to be had to do that. It's really a good era now that we have so many data in the public domain. And the other aspect is the dynamic models, and my colleague Viggo Andreasen and I have done this for a very long time also, and now with Kim Sneppen and his colleagues. And we're really using these tools to understand the mechanism behind epidemic spread. And with these tools, you actually can make predictions about what will happen if I put this vaccine in and started this program. What would I imagine happen 2 years from now? And these, of course, must be calibrated against real data, and that's something that's very interesting to me to get that done right. And then the challenge is, of course, to now we are understanding more and more that these models, the traditional models, the SIR models there, in which most people will just go to work and come home to a new wife every day and go to work to a new set of people every day. It doesn't work when it comes to COVID. It doesn't work for the pandemic so well. So we're starting to think about ways to really address the networks that people are living in and the context that they have. And I'm going to tell you more about that later. So this is really the excitement for sort of, what should we say, academically right now. So what makes for a pandemic? Well, all of them started in animals. There was, once upon a time, for every single disease you can think about that's epidemic in nature, measles, tuberculosis, anything that has been afflicting humanity, at one point in time, it was probably in some cow or bird or bat or something somewhere in the environment. So the way that we interact with the environment is enormously important in terms of understanding what the new pandemic threats will be and what's lurking right now. That's sort of the lowest level. If you think about avian influenza, we've been worried about that since 1997. It keeps lurking because it creates a few cases in the people who are around birds, but then it doesn't have what it takes to spread epidemically. And then MERS, another coronavirus is in that group, and Nipah. And then you have the ones that actually emerge and they do something. They actually manage to create epidemics, but they are not widespread. They do get contained. And that was SARS, another coronavirus in 2003, and the first time we really had an experience with a deadly coronavirus. And then Ebola, that maybe you remember from West Africa and Congo starting in 2014. That's also a disease that came from bats and was both of those could be stopped. SARS within a year and Ebola within a few years in West Africa, for example. And then you have the ones that really find out the trick to become a global pandemic, and that's defined as a virus or another pathogen that can spread epidemically in more than two world regions or more. And there we have, of course, the 1918 Spanish flu that most people remember, but we also have the 1889 pandemic, 57, 68, 2009, even HIV AIDS in the 1980s and forward, which is not one I'll talk about here so much, but there are certainly also epidemics other than the respiratory diseases. So that's really these levels. You start at the lower level if you're a virus and you sort of lurk, and then you come to the level where you can make little epidemics, and then if you're really good, you can actually create a whole pandemic and spread in the population and cause a whole lot of havoc, potentially. Now, the key trick to actually get there to be a pandemic is really to be able to transmit effectively amongst humans. Human-to-human transmission has to be effective. So that requires that the R0, the transmissibility, is over 1. That's sort of a key concept in our field. It simply means that on average, an infected person has to transmit it to at least more than one other person. And if you think about the 1980 Spanish flu, the R0 there was 2 to 3. And for COVID-19, it was about the same. Even SARS had that also. The R0 was about 2 to 3. So these are viruses that really have a potential to spread very well. But there's more to it. So I'm going to get back to that. So what is the historical experience really we have with epidemics so far? I don't have time to go through this horrifying history of epidemic diseases ravaging human populations, but I just wanted to tell you a few that you might not know about. One is, for example, in Memphis, Tennessee, which is a temperate climate place in the US, suddenly one year, yellow fever arrived and got endemic probably in the local vector, mosquito, Aedes, and then suddenly over just one summer of 1878, not that long ago really, 26% of everybody in Memphis died of yellow fever. Not only that, the people with the historic descendants from Europe, 70% of them died. So it was really, really a disaster, and then it was just a vector-borne disease, so it's different from COVID, of course, but it's another example of a pandemic, or epidemic in this case, because it didn't really spread in the whole of the US. In Denmark, I'll just tell you just for a second about the crazy thing. Everybody talks about what would you like, pest or cholera or something, or in Denmark, what would you, it was bad with the cholera, it was worse with the Spanish flu, but did any of you know that in 1831, there was an epidemic that made them look like babies, really? It's a really serious one that is my PhD student, who has a background in history, is working that up right now, trying to understand what the hell happened. In some little counties that are dark in this graph that he has made, 12% of everybody died in just the context of 2 months. Maybe it doesn't sound like a lot to some of you for a demographer that you should be falling down your chairs right now. This is huge, this is crazy, and we just don't know what it was. So that's just an example of what we do in our historic end of the studies. We try to figure out the etiology of this thing using all the tricks we have that we can find ranging from clinical descriptions to its epidemiology, and then to also study some other things that happened in countries around us at the time. But now I'm going to focus on the last 100 years. There was a centennial for the 1918 Spanish flu a few years ago, and that was a big year for people like me, nerds like me maybe. So what you're seeing here is the era of influenza A pandemics in the last 100 years. Starting in 1918, transferred from a duck to people, 57 partly from a duck into the old virus and creating a new one that was the H2N2 pandemic. 68, H3N2, and then in 2009, to everybody's surprise, not a duck, but from a swine, not from Asia, but from Mexico. So sometimes we get little surprises. Maybe the biggest surprise about 2009 was it didn't cause a lot of death, and that was very confusing to the pandemic community. And then we have the 2019 COVID, where it came from a bat. And then in the future, I'm putting what we call disease X. We really don't know what comes next. I would say we were a little myopic for a long time in this era here. I've been in pandemic planning since, I think, 1997 or something. And we could only think there would be another influenza A. But I think now we have learned the lesson. It can also be a coronavirus, but make it be something completely different that we hadn't thought about. So then we learned some things, however, from these historical pandemics. Here I'm showing 4 different ones where we can see it's just on the, trying to scale how many of the deaths happened in each of the waves. And you can see all of these 4 pandemics, 1889, 1918, 57, and 1968, had several waves and that's kind of something we expect will happen. There'll be several waves of a pandemic, and not always are all the deaths happening in the first wave. In fact, there are some unpleasant experiences where most deaths happen later on. So that's something that we have to take with us from the era of the influenza A pandemics. In terms of, if you want to summarize it all, I would say that the signature features of these, what we have learned from influenza pandemics is that, and others really, it's novel viruses. They come as a whole genome from a virus from an animal or partly. They have rapid transmission, probably are not around 2, is not unusual for a pandemic. And some of them, because they double very, very fast, like just in a few days, the generation time is short, you will have this exponential rise in cases very quickly if you don't do something. They have variable mortality, and that was a new lesson in 2009. We have the Spanish flu and 2009 pandemic in each end of the spectrum, ranging from a ton of deaths and terrifying 50 million deaths worldwide to not much worse in terms of deaths than seasonal flu. Then we have learned that in some pandemics, the mortality, in all of the pandemics, the mortality shifts towards younger ages. In some cases, it's all in younger ages, like it was in 1918 and 2009. And then we have seen in pandemics of these several pandemics, almost everyone I've looked at, except maybe 57, we've seen that elderly were spared due to, and this we know now from studies I don't have time to show you, childhood immunity building that they have from childhood, similar experience with flu that actually gives them an antigenic sin advantage, and therefore pandemics can go completely over their head. 2 to 4 pandemic waves is normal. The first one in 1918 was actually mild and immunizing, but in some cases the later waves can be more deadly. Really, we can expect anything. And so far, it's important to realize that every pandemic we've ever looked at ended by herd immunity. We, in some cases, had vaccine. We had a vaccine in 2009, but it came too late, and 2 waves had passed before it ever was ready to be used in people. So really, in our experience, we never had tried to control a pandemic with a vaccine. And also, we never, in our wildest fantasy, thought we could control a pandemic with things we do like lockdowns. It has never been done before. We thought we could dampen and delay, but we never really thought we could do more than that from this experience. So we meet the COVID-19 pandemic, and we have to start sailing this boat while building it and trying to understand what's going on. The first thing that is very nice to know is that phylogenetically it's enormously closely related to SARS. You can see that the new coronavirus, SARS coronavirus 2 is here very close to SARS. That was the pandemic threat in 2003. And then you have MERS, which is the coronavirus that is very deadly, hanging out in camels in the Middle East, spreading to Asia, but never making it as a pandemic. And then you have in the same family 2 common cold viruses. And that's why we didn't really have a lot of respect for this viral family. They just caused the common cold in winter. How exciting can that be? But really it turns out that these are quite closely related to these deadly ones. So, and that was actually, when I learned about this first, I thought, oh my God, this is actually a family of viruses that has it in it to be a pandemic virus. Because if you think about it, those two cold viruses must have been transmitted from an animal sometime in the past, and they must have been a pandemic sometime. And actually with Anders Gorm-Petersen and 2 awesome students, Amanda and Alex, we're actually going for this. We're trying to use the sequence data we can find in the public domain to try to investigate. And then if any of you saw the TV series that I was involved in over the summer, on Tuesday afternoon, Wednesday evenings, I think, on DR2, actually we did talk about this possibility that the 1889 pandemic was caused by a human coronavirus and not the flu as we thought in the past. But if you look at what really, if you just compare the SARS MERS and the SARS-CoV-2, the one that causes COVID, you can see these are the 3 viruses from the coronavirus family we have to reckon with now, and the emergence as in that column. And you can see that the 2 first ones caused relatively few cases, and then SARS was ended and eradicated. MERS is still lurking, but the fatality rates were enormous, much, much higher than for example, H1N1 pandemic flu. But the difference is that the H1 pandemic and the 2009 swine flu pandemic, H1N1 PDM, they swept the world and probably infected 50% of everybody or something. And then you can see that the case fatality rate, once you take that into account and count the deaths from excess mortality, you come to that there's a huge span of 100-fold in severity between these 2. And somewhere in the close, you see that the SARS coronavirus is actually quite close to the 1918 pandemic in terms of mortality, and that's a little frightening. So it's really important that we get this under control until we find a way to handle it with a vaccine or some better medication. In terms of globally, you can see here how the COVID swept the world. Yeah, I'm only showing data from April here, but you can see them from every world region. And you can see that there was a first wave in Asia first, and then it came to the Middle East, then it came to Europe. And we had these devastating outbreak in northern Italy that really freaked us out in February. And that probably led to the lockdowns of most European and many countries around the world. But you also have seen now that it didn't stop there. It swept then to the North America, South America, and they've just had a tremendous time struggling with this virus, with the most cases now in North America. And then you have in Asia, it's probably, of course, some of the countries are really large populations, so you're seeing India and Pakistan there. So this is not over yet, and even so, this will be with us for a while. It's like I mean, people talked about this pandemic as a 100 years event, and I think this is really true. This is a whole new species that we have to sort of deal with. In Danish data, we have Statens Serum Institute producing all these nice data all the time. You can just see, I just took this screenshot yesterday. You can see in Denmark we have outbreaks in the Copenhagen and Odense area, which is why we're in this situation. And you can actually go in and use these data to get a lot of information about what's going on. In terms of tests, we have the PCR test for acute illness. Have you all tried the throat swab? Yeah? Yeah, me too. It's not so fun, but it's good because then you find out if you have acute illness. And then we have the serology antibody test, which is to know if you had the infection in the past and the immune system has reacted and you have the antibodies. And what I'm really excited about, what seems to be coming now, but it hasn't really gained a foothold, is a rapid RNA test, something where you actually potentially one day can be having a test at home, get up in the morning, have a cup of coffee, spit in a cup, and then in a 15 minutes to an hour, you will know if you were infectious that day. That would really be a game changer. I don't think we're quite there yet, but I don't see why we couldn't get there if we really can get to Mars and everything. It's not a technical problem, it's more like, can you actually do it? And one of these tests, for example, they're using in the UK already, is at the same time testing for flu and RSV viruses, so it'll be very handy going into the fall. Okay, here's a couple of tricks why COVID made it and not the other coronavirus. What was special about COVID? Well, trick number one was that this virus is infective several days before you know you're sick. And not everybody is sick, but if you are infected and you are doomed to have fever 2 days before you actually can and transmit it to other people. This makes it under the radar, difficult thing to control, and probably was the reason why there was no way we could stop it in the first phase where people were tested if they came traveling from skiing vacations. If they had a fever, they could easily have been in the incubating phase and not be stopped at all, and then be infecting a lot of people. Trick number two, a broad clinical spectrum. This SARS was easier that way. It was most people got really ill, and certainly you could see in respiratory symptoms in everybody. But here you have maybe half of everybody get asymptomatic disease. And in a new study from Pakistan, possibly 95% of people who seroconverted never knew they were ill. So this is an important part of the spectrum. This means that if you study it, you'll be up there in the tip of the iceberg, but really there's a whole mountain of other infections that are hard to see because they can be mild. The first trick is that we thought for a long time that this virus behaves a lot like flu. It's fomite transmission. You can stop it if you are 2 meters apart because these heavy drops will fall to the ground and hygiene and everything. This is all good and everything, but we are understanding more and more it's not all there is to it. There's also aerosol spread. And therefore, we have these mass events where it probably stays in the air much longer and can affect people who are not exactly just people who are far from you in the room. So that's probably an emergent field here. The most significant or specific symptom of this silly disease, really a difficult disease, is loss of smell and taste. It's just like, that's actually the one that bongs out in this study of self-reported symptoms on the UK smartphone app. You can see that 65% of everybody who later tested positive, at the time tested positive in a PCR test, they had lost this sense of smell and taste. So that's a good one to remember. The other ones it's really a hard one to catch. It looks a lot like a lot of other diseases that are caused by respiratory viruses and bacteria. And then there's been a lot of talk about that it's just all about preventing mortality in the elderly. I've even gotten some emails to suggest we should just put elderly people in a basement somewhere and then the rest of us could live on. Of course, this is far from the truth. There are younger people who get severely ill. There are now a bigger understanding that this is also a disease of the inflammatory disease that can affect even children with something that looks like Kawasaki's disease. And young people can present with a blood clot instead of with something else. So it's really it's a much broader spectrum of things that are not typically respiratory disease. Plus, we are understanding more and more that some people end up with a persistent problem with health for a long, long time. And of course, we can only know 8 months because we're only 8 months into the pandemic. But how long this will last and how common it is, that's really something that we don't know enough about yet. But that's the reason why even young people should try to stay away from this disease. Okay, now about the COVID-19 pandemic. What's really important about it is that unlike the pandemic flu, it's a very, very steep ascent in risk of dying when you get old. And actually in these data from China, the median age at death was 70 years with a crude case fatality rate of 2.3%. But of course, as you just gather from this, if you have a population with a different demographic structure, this would be really an important factor. And then when you look at Denmark, for example, and Italy and Spain, the mean mortality age is 80. These are aging societies, and the mean age of death is 80 years. So, but what I want you to take home from this is really that it's really super high when you get over 70, 80, 90 years of age. It's just like explodingly high rates. And the worst is in nursing home populations where we have frail elderly, and in outbreaks we've seen mortality rates of 30% in those who were infected there. So that's really catastrophic in some age groups. From seroepidemiology, we're getting a lot of information about how many people really had the disease. For all the reasons I told you about, it can be hard to gauge. So we have from the Danish blood bank studies, which is a convenient sample, but it's very good, an idea about how many people from 18 to 70-year-olds who had ever had the disease and converted and recovered. And then we have from the Statens Serum Institute a randomized study where we're trying to invite people to come and participate in a randomized study, and that is in principle the right thing to do. In practice it's a trouble because the participation rate is very low, so it's probably just a goody-good to show up, and then it's really hard to make a sense of these. It's hard to say which one of the two are better right now, in my opinion. But here's some data we try to extract from them, and you can see from this is a little busy slide, but you should be able to see that if you go instead of looking at the case fatality, you look at as a denominator the ones who ever had the disease from serology studies, you get that the true mortality rate is probably in the blood donor study 0.4% and in the randomized study 0.9%. So this is much better than the 2.3% that we saw in the early Chinese study, and it's probably in that league that we are. And that's better, but it still is a high rate relative to other diseases. I just put in I love what Iceland is doing. They have a rich tradition for sequencing everything, and they're just all over this COVID pandemic, and they just published this beautiful study a few days ago, and there you can really see that they have managed to control the disease very well. Less than 1% of Icelanders have ever had it, and they provide a very important piece of evidence, which is that antibodies did not level off. And this was one of the unknowns, really. And this is a really bad unknown if you don't even know if your protection from the first infection lasts. So now, at this point, they're 4 months out, they see a steady antibody level, and they'll probably use this study to go on into the future and inform us about how long-lasting the antibodies and immunity will be. Here's EuroMomo. If you don't know what to do with yourself one day, you should go in and look at the EuroMomo. It's a beautiful study of mortality in European countries, and you can just Google your way to it easily. It's Statens Serum Institute started this some years ago, and now it's coming in really handy because you can certainly see the excess mortality there by age and what have you, and that's all due to COVID. And this is another way of approaching mortality. One way is to take 100 patients, try to figure out how many of them would die from clinical studies. The other general way, and that's what I've done most of my research in, is to say, well, let's just see how much happened in excess above what would be expected during the time when COVID was around. And that's how we can begin to understand how deadly this disease was. So the young age shift was typical for pandemic flu, and I just wanted to show you that if in the middle column that we have all kinds of mean ages at death for different pandemics. Most notably in 1918, the mean age was 27 years of death, totally different from COVID-19, which is 70 or 80 years. And I just want to say that we haven't done this yet, we haven't talked about this yet, but really if we count deaths, any death will count the same. A 10-year-old with 90 years to live will count the same as a 90-year-old with 2 years left to live as life expectancy. But if you then do years of life lost instead, we try to do that by other pandemics, you can see they sort of adjust. The 2009 suddenly looks a lot more serious when you do that because it was young deaths. And that's what I think we have to do one day for the COVID. We have to add this on top of everything we know about it, an idea about what happens if we adjust for the fact it's a virus that kills elderly and not young people. So mitigation, we have country lockdowns. It has been the strategy used for most countries, and I think really it came because of the shock about that. Even in Italy, a democracy, in cities like Milan, or places much like Copenhagen, you suddenly had a health system that was on its knees with overfilled ICU departments and morgues, and it was just like totally horrible. So Denmark and many other countries, I think on that ground, chose to close down at that time, around March 11th, 12th. And only Sweden stood out, and they didn't do it. And I'm following Sweden very closely for this reason, to see if they actually was onto something. They just did what we always do. They try to do hygiene and everything, but they live in an open society, they do not use masks, and they have another approach to this altogether. What's really important about this lockdown idea is that it's very expensive economically and for people's happiness and all of this. So it has a huge socioeconomic price. And really, when you see countries, middle-level countries and low economies doing this, you sort of hold your breath, because what can happen, and it has happened, the EPI childhood vaccine programs have stopped, because they don't have the capacity to deal with the childhood infectious diseases all of a sudden. And you see places where there's probably been a trouble with famine and access to water, because when you lock people down and there's no wealthy infrastructure to carry this forward, you can really end up in terrible trouble. So and there's really another need that we have to, probably will get to this, we did with Ebola suddenly in 2014. We have to understand there's also a secondary disease burden around this whole pandemic that we have to deal with. But this is what happened in Denmark. We locked down on March 12th, and then we start gently reopening to start to see if we can live a more sustainable lifestyle. And this is what happened, and this is actually where I was surprised so many times. I was trying to explain this in radio and being confused. First of all, it works really well. You lock down, you never think this happened, but actually totally stopped this pandemic on its tracks, and so it's like we had a button we could turn it down with. And then as we opened up in 3 phases during April, May, and June, it kept going down, and this is against all the classical models. You'd think it should be rising again, but instead it kept going down. But now that we have more opening here, and we are seeing in the R, I told you R naught was 2 to 3 if we did nothing. Now it's 1.5, and trouble are brewing, and this is why we have such a small audience here today, I'm sure. But then this is exactly what we have to find a place, and now we are going down to we can only meet 50 people. It's all in the attempt to try to find the right level. We sort of have to titrate our way to the sustainable strategy until we find a vaccine or some other solution. But this is Sweden, and I think people have forgotten to look to Sweden. Sweden got a terrible rap because in the beginning they had so many deaths, and mostly in elderly in the nursing homes and in Stockholm and other places. But then their open strategy must have worked really well, because if you look at it, their cases in blue there are going down and down. This is death, actually. It keeps going down, and it's right now not so different from other European countries, despite they had this completely different strategy. So I'm saying look to Sweden. They are known for the badness in the beginning, but they're not so known for the fact that they're doing really well right now. It might be a strategy that could be useful for countries that don't have the economy to lock a country down. I'm going to just briefly mention there are silver linings too. For example, that seasonal flu seems to have completely disappeared. Data here from the southern hemisphere is just gone, probably due to all these things that we do. Flu can't get around either when we wash our hands so much. So then the super spreading, my favorite topic of all things. If you remember back to Austria, where really a lot of the cases came from, it was from a skiing after skiing bar, where there was a bartender who actually turned out to be infected with COVID, and he had a whistle, which probably helped him aerosolize this virus in the room. And then he had a big crowd of densely packed people who were there. And what happens? All these people went back to Northern Europe and seeded most of the strains that we have in countries like Denmark and also Norway, I think. So this was an immensely important thing, and this is really a super spreading event. Probably one person infected a whole lot of people, and we don't understand the mechanism of this. Is it the man who was the super spreader? Is the situation that's a super spreading event? But we really need to understand this, because this is important. This is not a new theme. I was not surprised when I saw that, because when we worked up on SARS in 2003, this was what was talked about all the time. It was like a super spreading thing, and you see the left graph here. You see in Beijing spread of SARS in 2003. It was like some people transmitted a whole lot, but most people didn't transmit very much at all. So, and with MERS, it's even more extreme. So this is really a theme with this class of virus. This must be important. So if you look at it, it's like from countries that actually looked into this, there's a theme that 10% of infected people end up infecting 80% of the next generation of infections. So if you can only get at those 10, right, then you could really, in principle, stop it because the rest cannot carry the epidemic in and of themselves. I list a few examples here of super spreading events. There was a famous choir in the US where people met and they were very careful, kept distance, washed their hands, and 2.5 hours later, 85% of them were infected and 2 of them died because it was an elderly choir. A bar hopper went 5 places and infected 60 people in just one night. Church events, meat packaging events. And then in Denmark, just yesterday, a private party, 30 people, young people getting together and having some fun, were infected after probably just the presence of one super spreader in there. And then you had these 500 US bikers that met in August in South Dakota, and they didn't have masks. They were very close together. They don't believe there was a virus. And then they all biked home to their home states. This horrifies me. This is like the archetypical, worst possible, perfect storm scenario. But that's actually happened in the US just in August. So we were thinking, could this be like an Achilles heel for the virus? Can we understand the dynamic of the virus when you start actually dealing with the fact it's not just 2.5 infections from every person. It's some people it's around 1, and other people it must be super high in order to explain this 10/80 distribution there. So Kim Sneppen, he took out his old agent-based model that he once developed for language, to understand language development in Japan or something like that. I can't really explain it, but it's very cool what he's doing. And then in these panels, it's going to be a little hard for me to explain, but in the first panel there, you're just looking at a model without super spreaders in it on top. If you didn't mitigate anything, what would it look like? And with and without super spreader, you can see there's really no difference. So that's why people were not that excited about it. But when you start mitigating, you start seeing this. And in this model, people transmit in 3 compartments: at home, at work, school, or at parties and in the public transportation, concerts, events. So you can see in the middle one, if we close down the work and school, things we absolutely must do in order to keep the society going, there's not a lot of difference between the model with and without super spreaders. But in the third column, when you close the outside events, when you close down the super spreader possibility events, the big gatherings, all of this, you suddenly see this epidemic goes and almost disappears. And this is really a beautiful result that shows that actually control can be achieved by limiting large events, limiting opportunities for super spreaders. It also made me think, now we understand why we were so successful in the lockdown, and now we can explain why it didn't go up again when we start reopening the country. All these, the model can track these data very easily. And on top of everything, maybe we can even now understand why we managed to get rid of SARS in 2003. So this is like, this was like a really big aha moment for, we have worked late nights on trying to write this. We're trying to get this paper published now, but we think it's just amazing. And we're working on many permutations out of this, such as, for example, is it then easier to track infection chains when you have this heterogeneity in spread, as we obviously have. How will this end? This be approaching the end here. Well, normally it ends with natural immunity, but we're not getting that far. In Denmark, we only have 2 to 3% of the population have ever are immune to this virus or have antibodies. In Sweden, a little higher. In New York City, even higher. But it's really not anywhere near this 50% you normally would expect in order to achieve herd immunity. So we're waiting for an effective vaccine to come along. And this is really a big trick to do that, because it's a new class of viruses. We fortunately have a head start with the 2003 vaccine early start point. But it's really something that requires intensive tests for both safety and efficacy. And that requires phase 3 trials. And that requires 20,000 people in each arm of the study. And so that means you have to have an epidemic where people actually will be in this trial. And I would say it's optimistic if we have a vaccine in a year. It could be longer. So in the meantime, we have to find a strategy for living with it while we are waiting, and we can continue this tight epidemic control that we know we can do with all the good things that we do. In Denmark, we really have found a way, I think, to do it pretty good until recently. But it really, in my opinion, would be a game changer if we got a test that people could do themselves at home or in the workplace or maybe in front of the concert. That you could just take a test outside and you could walk in and everything would be fine. There's something about this testing we have to get better at. But the case of Sweden has to be considered here. Is it really so that the one thing that I didn't tell you about what Sweden did early on, I think they were really lucky. They locked down big events. As we were closing down the whole country, the most dramatic thing they did was to limit events over 50 people. And they've done that systematically, they've changed nothing else, and that's probably, in my opinion, because of the super spreading business, that's why it came down the way it did. So we need to understand that better, obviously. And then we need to understand more, we need to talk more about COVID in the low and middle income countries, especially think about what happens with this virus if it meets a young demographic. And actually this morning, my student, Søren Ørskov, called me and said, did you see in Pakistan they now did an antibody study, and 95% of the people who had antibodies were actually reporting they've never been sick. And the average of the mean population age there is 22. So maybe there are places where this virus actually can get quite far and maybe even get to herd immunity, where actually most people will be under 50, 60, 70, and therefore they won't even get very sick. There'll be the long-term sequelae, and some, we don't know how many, but many of these people didn't even know they were sick. Similar data from a slum in Mumbai, India, where suddenly 60% had antibodies, but it was like, we didn't hear so much about the disease and deaths from there. So much more to learn from there. And especially it's important because of it's so expensive nearly impossible to close a country down that doesn't have the infrastructure. So in terms of the vaccine, I'm really done almost. One thing is to have a vaccine working in a monkey. Another thing is to have a vaccine that actually works in populations, requires all these phase 3 trials and everything. But once you have a vaccine, there's more questions to be had. And here's a list from David Baltimore, who's an expert in vaccine areas. Really does it, how many doses are needed for protection? Just how soon will it be available? Can we have enough of this for everybody in the whole world? How should we prioritize? Does the vaccine work if you're over 80? Certainly flu vaccine doesn't work so well for that age group. What about the kids? Is that a problem with Kawasaki, with the vaccine? All these questions will be hard to have an answer to because the clinical trials, phase 3 trials, take place in young, healthy adults. So there's lots of questions that we'll still be having even as we have a disease vaccine readily available. So will there be a future pandemic? Yes, there's always one. You can see all the data from my last 100 years. Every 10 to 40 years there'll be a pandemic. Could it be as deadly as 1918? Maybe, it's possible, but let's hope not. Could it be another virus, an influenza A? This is an old slide, obviously, because the answer is clearly yes, it could be a corona. It could also be a lot of other things. Bill Gates is worrying about that now. That must be real then. And really, WHO started calling this the disease X, a mystery illness in the future that could be killing millions. And this is a list of and to WHO's credit, they actually had the coronaviruses on their list, blueprint list of things to worry about. This list was made in 2017, I believe. And then they also have this disease X. So that's just the unpleasant news for me, that we are still struggling. We're not done with COVID-19, but in the future there'll surely be another one. So we better get better at preparing, better at working together between the universities and learn as fast as we can, and then do the best we can every time it happens. Thank you. And then we have some time for questions. Yeah, Susanne.
Thank you very much for a great presentation. Do you dare to speculate on the main reasons for the big spread in symptoms?
Do I dare to speculate about the broad clinical spectrum?
Yeah. So what are the main reasons why some are asymptomatic, some come
Well,
down
I
with-
think this is really something we need to figure out. I mean, if I was Peter Åby, which is a South Danish University researcher here, has done beautiful studies showing that actually measles, for example, it depends on what dose you get. Could it be that some people in some settings you actually get a higher dose and that leads to more severe symptoms? It's possible, but I don't know that we know that. And then age groups, obviously, age is a big thing.
Sure.
And there's a big Nature study that came out about a month ago that lists all the risk factors for getting, for dying. So clearly, people with certain chronic diseases are more likely to show more symptoms than people who are otherwise very healthy and very young.
So, but if you take young people, for example, most do not have really strong symptoms, but other come down with quite significant symptoms.
There's also genetic risk factors, and there's one study I've seen where actually the blood type A turns out to be bad for you. Okay. But I don't know that we know enough about that yet. Yeah. There's probably genetic risk factors as well.
And does it matter how you get the disease or how you get infected?
Well, I've been noticing that actually there's a lot of younger nurses and doctors who tend to get quite sick and or die, both in China but also in Italy and the US now and other places. And I've been wondering if there's something about that you're in an environment where you just get a high dose or something or you get it deeper into your lungs or something happens in certain settings. I don't know. I have to say it's not really my top competence, so I can't really say more about it than it's really an important question. It's very clean.
Thank you for a beautiful talk.
Thank you.
So, you said that these pandemics comes in waves?
Yes.
So why are they coming in waves, and what is the initiating event starting these waves?
Yeah.
Is that necessarily super spreading?
Yeah. Now, for the waves that we know about come from historical pandemic flu. And we know for influenza it's a very democratic disease. It doesn't have a super spreader thing. It's more like everybody transmits about the same. So it's not the super spreading thing. But the question is really good. Why does it stop? Why does it stop and come back? And the historical explanation has been that this genetic drift, the virus escapes the building herd immunity in the population. But I don't know if it's the full story really. I think there's I don't know if you have any ideas. There's something that we're not capturing there somehow. But the observation, nevertheless, is that that's how immunity builds up over a period of 2 to 5 years to about 50-60% normally.
Okay, thank you. So I also have a question.
Yeah.
Can you hear me?
Yeah, hi.
Okay.
Søren?
So the question is about these super spreaders. Do you dare to speculate why we see such great heterogeneity between how much people infect each other? Is it social behaviors, genetic, or is it age groups, or do you have any kind of ideas about why we see?
You mean in Denmark right now?
Yeah, well, everywhere I'm assuming. Just super spreaders, why there's some people that are super spreaders, for example.
No, we simply don't understand the phenomenon. We saw one outbreak actually where someone, it was a Chinese study from January, where one person first went to somewhere and infected 30 people. And then he went home and infected everybody in his household. Now that kind of information makes me think that certain people just have it to be a super spreader. They might have a higher viral load in their throat, or they might be better at aerosolizing the virus or whatever. It might be that some people actually are better that way. But I think I'm really also on these crowds. I mean, to get close together, that biking incident in South Dakota is killing me. That people just do this and with such a high infection load as they have in the US right now, it's like it's a perfect party for that virus. So it's really behavior is an important part. I don't know why it is in Denmark right now. It's mostly the 20 to 29-year-olds who seem to be leading the field in terms of infections. It's not so associated with particular places. In Odense, it was one study, there was an outbreak there, but in Copenhagen it's not like that. It's more like it's hard to tease out where these, who are doing what and why it is, but the suspicion is that young people tend to be more likely to drop their guards and hang out in big crowds and party a lot.
Thank you.
I don't know if I answered your question. I did my best.
Yeah. Thank you, Lone, for a great talk.
Thank you.
So these waves, can we see any difference from pandemic to pandemic regarding the effect of lockdowns, for example? So is it just this genetic drift, or does it actually have an impact that we lock down?
Well, the lockdown that we are trying right now is exceptional. It's draconic. It's not seen since I think the last pandemic wave we had of plague in 1711, where Helsingør was walled off. This is extreme, so we have really no experience with what will happen with under such a lockdown. The reason why we started with the things like closing events in schools is really all from the 1918. 17 cities in the US decided to do different things. Some did nothing, and some closed schools, some closed events, some closed various things. And out of all this information, you gathered that red curve and the green curve that everybody knows from the media. And that was the whole idea, that somehow by doing all these things, you could sort of press yourself down to the green one and avoid doing too much with the society. But that's sort of historical data helping us with policy now. But other than that, we really have no experience with the lockdown, because where would you go and look for that other than the Middle Ages? Then there's no data. And besides that, 1711, one guy came out and started an epidemic in Copenhagen. That's it. Are there any questions from people online? No? Well, in that case, thank you.
Then I, on behalf of DS, would like to thank you very much, Lone,
Thanks for the invitation.
And we are actually planning doing twin family studies, so that might be a way to look more on who are, because you can study who's living together, who's sharing genes, and who's only sharing environment, and so on. Might be
So SDU collaborations, and we have Christian Møller-Dahl sitting here. We certainly tried to collaborate, but we did not get the funding yet, but we will one day.
So we noticed your invitation on the slide, and it's well accepted. Excellent. And we'll talk more after this.
Certainly.
And I'll like to thank everybody for coming today. Although it was a very limited crowd, we were allowed to let in. But you behave nicely, and I guess we should when it's with this talk in particular. And also thanks to the many who followed us on YouTube. So thank you.
Thank you.